afternoon, everyone. My name is Olivia Hensley from the New England QIN-QIO, and I'll be moderating today's webinar. Thank you for joining us today. Today's webinar is called Making Your CASPER Data Work for You, Part 2, a data-driven approach to improving your outcomes. Before we get started, I'm going to quickly review a few housekeeping items. This call will be recorded for training purposes. I'll provide you with details on accessing the recording at the end of this webinar. The phone lines will be on mute for the duration of the presentation, and we'll take questions at the end, and I'll provide you instructions on how to unmute your line, or you can pose a question in the chat box. At this time, I'm going to introduce today's speaker, Ann Olson. Unfortunately, Kathy Roby was not able to present today. However, you are in very capable hands with Ann. Ann is a home health expert supporting the New England QIN-QIO. Her past experience includes serving as the CEO of Interim Healthcare of Hartford, a full-service home care agency where she drove consistent quality and financial outcomes and led diversification through expansion to include a licensed home hospice division and a registered personal care and support division. Please welcome Ann.
Hi, good afternoon, everyone. I hope you're all doing well and enjoying a sunny day and wherever this call finds you. It's so nice. We were just having way too much rain last week, so I don't know if how you all feel, but it's been a very welcome change having some sunshine. So we're thrilled to be here today to talk about some important information about how to access your CASPER data. Just to give you a brief overview again of who we are. As Olivia mentioned, I'm with Qualidigm. I'm a vice president here, representing the New England Quality Innovation Network, the QIN-QIO. As you know or might not know, CMS had modified their QIO program. There used to be 53 contracts throughout the country, and they did consolidate that down to 14 Quality Improvement Network QIO contracts. And so Qualidigm and Health-Centric Advisors is the QIN-QIO for the 6 New England states. As you can see on the slide, Health-Centric Advisors, which is located in Rhode Island, focuses on Mass, Maine, and Rhode Island. And Qualidigm, which is where I work, we're focused on the Connecticut area, and we also oversee New Hampshire and Vermont. So we do want to just invite you all to please visit our New England QIN-QIO website. There's a tremendous amount of information there that you can access, and we really welcome you to view that. As I mentioned, working in the 6 New England states with Health-Centric, we are providing tremendous amount of education, and we really encourage you to visit the website. You can see here, if you do sign on and go to the website, you can just click on For Providers, and then that will bring you to a multitude of resources and information that can be helpful to you on a daily basis. So today's agenda, we're really, as I mentioned, looking to refresh your knowledge of the CASPER system. We actually had kind of a record registration for this program today, and I believe I'm speaking for all of you in that all home health agencies are feeling the pressures to really be monitoring and improving their quality measures. We all are very focused on star ratings and implications of that for us as providers. It's something that is really going to make a difference in terms of our market share, our sustainability, our ability to really compete in this ever-changing industry that we're in. So we are really excited to review the CASPER system for you, not only for the star ratings, but also thinking about value-based purchasing, which, as you know, was released in January of this year and is impacting 9 states. But it is something that will be coming to all of us, and knowing where your quality stands and working on that to improve it will really position you for home health value-based purchasing in the future. We're also going to be describing how the data is developed, reported, and used. We'll be looking at some of the critical reports in CASPER, and this overview will be just kind of an overview. Obviously, you'll need to go in and really play within the system, but hopefully we can highlight for you those critical areas that will help you on a day-to-day basis focus on improving some of your scores. We also want to talk about setting some goals for targeted outcomes. Obviously, that's where the rubber hits the road. We need to really look at what are we weak in, where are areas that we can improve, and then set those goals and target them for improvement. We also are going to talk about some of the reports that you can use to create PDSA plans, and we'll be reviewing that whole process. And bottom line is the CASPER reports, as I mentioned, really can help you to position yourself for success in this ever-changing market that we're in. So where does the data come from? As you know, the Home Health Compare really is delayed in terms of the reporting of outcomes. We all wish that it was a more up-to-date report, but it's not. As you all know, what's on Home Health Compare right now is really looking at October 2014 through September of 2015. And when you're looking at the rehospitalization data, which are different dates, that's July 1st through the 30th of 2015. So it's really hard to be looking at improving your scores when you're working on old information. So the important piece about CASPER, what to understand here, is that the data is something that is as real-time as is available through the OASIS data that you submit through CMS. Obviously, if you all have OASIS scrubbers, you can be using that data as well. But this is the risk-adjusted information that's based on completed episodes that you submit with your OASIS. And a completed episode, as you know, is a start of care to transfer or discharge, or a resumption of care to transfer or discharge. The outcome measures, I'm sure this is a review for you. That really is looking at what was the end result of your episode. And then the process measures, meaning what was your process? How did you work so hard to arrive at that end result? So looking at the CASPER access, and I'm sure you're all probably thinking, oh my gosh, this is what I need to know, right? Many of us have, with the busyness of our days and agency demands, you don't get to the CASPER site frequently enough. And then when you do get there, you're confused as to how to access it and what do you do first and second. Obviously, this is really critical to maintaining your knowledge about your agency. And hopefully, when we review these steps, it can help you to understand how to access the data and then what to do from there. So when you do log on to the KEYS national system, you will need your user ID, that is your provider number, and your password. If you don't know what your password is, you can see if you're unable to log in, just click on the link there, and that will prompt you to get the information you need to be able to log in. We've heard of many agencies that, possibly your quality person left and they left with your password. It happens. Don't feel like you can't, submit that you don't know what your password is. You've got more company in that category than I'm sure people would like to admit. So it's important that you figure out your login, get your password, and be able to get onto the system so that you can get access to this great information. So this next slide is really just showing you what you'll see once you're able to log in. And the red arrow is pointing to the CASPER reporting link, which is where you would be clicking so that you can get to all of the reports that we're going to be talking about. And once you're here, you get to this little more colorful slide. It's got, a lot of information, but as you can see up on the top right, it's giving you several opportunities to access information. The one that you want to click on is the Reports tab, pretty much in the middle of that, those tabs at the top. And once you click on that, you're going to see this section here that says Report Category. So when you click on that, you'll see the drop-down. You can see Home Health Agency Provider, OASIS, OBQI, OBQM, the OASIS Home Health Survey Reports, which most agencies use their CAPS vendor to access that information. And then the OASIS C Quality Improvement Reports. The one that you're going to want to click on is the OASIS C Quality Improvement Report, or Quality Improvement tab. So once you do that, you're going to see access to a number of reports. And we wanted to just highlight to you, this is really a slide that you really want to keep close to your computer. These are the ones that you want to click on. There are a lot more reports that are available in the drop-down, which can get confusing. So you really want to just keep this as your go-to list, because this really will give you the information that you need to really drill down and understand what's going on for your agency. So the 5 essential reports, you can read them, but I'll just go through quickly. Number 1, the Agency Patient-Related Characteristics Report, and that really provides a thumbnail sketch of your agency population, so just giving you kind of an overview of what your population looks at. Number 2 is the Risk-Adjusted Outcome Report, and that really compares your outcomes. And again, that's the end results of the care provided. But it also accounts for the differences between your population and the expectations for patients who are like yours. And that's, we're going to be talking about risk adjustments and some case mix considerations. That's where this report will take that information into consideration so that it's risk adjusted. The third report, All Patients Process Quality Measures Report. This is the same process as in number 2, but again, it's looking at your process. How did you get to your outcomes? The fourth report is the Home Health Agency Trend Analysis Report. And this is a really great report, and we will show you a screenshot of that as we go forward. It's really important because it compares specifically the selected outcomes month over month to track the impact of your process improvement plan. So again, this is more current data than you can get on Home Health Compare. And as we know, when you're working so hard to improve your outcomes, you need to see improvement. It's important for you as managers. It's also important for your staff to share this information so that they can see how you're improving and how their hard work, how the changes that you're making are really making a difference in your outcomes. So this is a great way to show that and to really celebrate your successes as you go forward. And the last report, number 5, is the Agency Patient-Related Characteristics Case Mix Analysis Summary Report. And this really allows you to identify a specific population that you want to focus your efforts on for your targeted outcome improvement. And we're going to be talking about some examples of that later. But as you know, it's important to be able to drill down to some specific patient populations that you want to focus on. And the last report that's up on the top right is a desired report. It's a risk-adjusted, potentially avoidable event. That is something that we all track from a agency standpoint, looking at your potentially avoidable events. And this is a great report, not an essential report, but one that can help outline that for you as well. So looking at improving your outcomes with a PDSA approach, it's really important that we look at all of the different variables that will help you to improve your outcomes. And again, this is the OBQI being the outcomes-based quality improvement efforts, your PBQI, which is your process-based quality improvements, and the OBQM, which is your outcomes-based quality management initiatives. And when you look at the circle and all of the intersecting circles, it's important to know that all of your efforts really do interact and intermingle with each other. It's not going to be just one particular effort that's going to make the difference. It's a combination of looking at your OASIS and collecting the data accurately, making sure that your OASIS proficiency is where it needs to be. Looking at your measured patient outcomes and interpreting the reports that we're going to be talking about. And then targeting a specific outcome and investigating what processes possibly were not supporting the outcomes that you were trying to achieve. What's working? What are your strengths, your problems? What are the best practices that are helping? And then looking at an action plan based on all of those pieces to develop the plan, implement it, and monitor it, and then start the whole process again to say, okay, what worked, what didn't, and then move on to your next initiative. So where do you begin? I know that it seems overwhelming at times. Home health has been bombarded with so many changes and so many challenges. Again, I need to stress to you that using your CASPER data really will help you improve your star ratings and position yourself for value-based purchasing. So it is time well spent, and I congratulate all of you for being here on the call today to really try to understand how can you do this, what data can you access, and what do you need from CASPER. We're going to be talking about the case mix, which is a critical piece to the risk adjustment, as you know, and I'm sure that there are many different agencies on the call with many different populations, from an aging population to high cardiac or behavioral health is a tremendous challenge. So really looking at how those might be impacting your outcomes, your hospitalization rates, etc. We're going to be looking, as I said, at the process outcome reports and really trying to look at some targeted outcomes from these reports that can help. So the next slide really looks at some of the data reports that are available. This is the first report that we talked about, the Agency Patient-Related Characteristics Report. I'm sure many of you have seen this. This is something that, again, is a critical piece to drilling down your data, and this is the way it will display. So you're seeing what your current mean is, and then the reference mean, meaning what is the reference to compare yourself to as a benchmark. How are you performing as compared to all of the cases in the reference sample? So in this example, up on the top right, you're seeing the current period, and then you're seeing the number of cases for your agency, and then the number of cases that have been submitted through the KEYS system, through all of the Medicare certified agencies. That is how they're coming up with that reference mean. So obviously a huge number, so a very valid and statistically significant reference sample that you can compare your performance to. The next report is looking at all patients' process quality measures. Again, we talked about the process measures, that it's really looking at how did you get there. So these are more geared toward, timely initiation of care. That is obviously a process. How are you doing as compared to the reference sample? Again, in this example, you're seeing the white is the current performance for your agency, and that is displaying at, I believe that says 99%. I'm squinting a little bit. And then your prior performance, which was 99%. And then the reference is 92%. So you're actually above what the national reference is. This is an area, again, I'm a firm believer in congratulating staff on their efforts. You don't always want to, or only want to relay the bad news. These outcomes are things you want to tell people, great job. Look at how we're measuring as compared to the rest of the country. Looking at care coordination, again, these are critical pieces to the care and the services that you provide. Process of assessment, depression being obviously a critical area, and it goes on from there, as you can see. But these are really important high-level categories that you can look at and, again, share with your staff, and then look at as we move forward with a PDSA plan as to how you might impact or improve them. The next report is looking at your risk-adjusted outcome report. And again, this is the outcomes versus the process. So this is, what did you do, actually. So we're looking at the improvement in grooming. And again, these are the same breakdown when you're looking at the reporting and the bar graphs there. So for the first one, for example, improvement in grooming, unfortunately, this agency is scoring a little under what the national benchmark is. So this might be an area that you'd want to focus on. Improvement in toilet transferring when you move down a little further on this report at 64%. But it did show that even though your current is at 64, your prior was 67. So moving in the wrong direction. So again, there are many trends that you can take from these bar graphs that can show you, how you're doing, are you improving, or are you slipping a little bit. As we all know, sometimes you put a great plan in place and things get better, and then unfortunately our attention to that might slack off a bit, and the outcome will reflect that. So again, this kind of report is really important that you're consistently and frequently looking at, so that you can see how you're doing, how your improvement plans are working, and if there are any improvement, congratulate your staff, and if there's any sliding off and going down, that you want to really consider putting another plan in place to impact that. So how do you establish a plan? What additional data do you need from CASPER? So I mentioned when we were looking at the different reports, or the different reports available, that there is a Home Health Agency Trend Analysis Report. And again, this is looking at what your trending is as compared to your rate and the risk-adjusted rate. So that's comparing you to agencies like your agency, which is really helpful to do, and it's important to keep that in mind. Also looking at, running your, or analyzing the characteristics of these negative outcomes. So looking at who, meaning which cases, which patients, and I bet each one of you could mention maybe 2 or 3 or 5 patients that you know of that are causing your hospitalization rate to be higher than you want it to be, or some other patient challenges that you just know that patient that you've had for a significant amount of time is causing you to have some negative outcomes. But there are reports available in CASPER, specifically this tally report, which we're going to be talking about, that gives you the ability to drill down the information to particular patients and seeing, okay, so if I scored low on one of those outcome or process measures that we talked about, who are the patients that are driving those numbers? Where is that coming from? It's probably the 2 or 3 or 5 patients that you know about, but I would dare say that there are some patients that you don't know about, and that's what this report is going to help you to do. So looking at the next, at this trend analysis report, this does give you a nice overview of where your agency is as compared to your actual rate. So this is your actual OBQI reports, and then your risk-adjusted rate, which is available on Home Health Compare. So it's really comparing those two reports, and you can see how that ranges very close to where the actual is, but it's what is publicly reported on Home Health Compare. It's important for you to see that these are very much in sync with each other, and is there opportunity to impact those. You can also see further down on the breakdown, it goes through month over month. So in this example, we're seeing February of 2015 through January of 2016. Again, this is much more current data than is available on Home Health Compare. So this is something that you really want to be taking a look at, and then how your agency is rating in terms of your risk-adjusted score, how you're scoring as compared to the national references, and you can see the different percentiles broken down there as well. This other report is just a more detailed emergency department with hospitalization report. It's the agency patient-related characteristics analysis summary report. And again, it's drilling down further in terms of one specific area that you can see the emergent care, no emergent care, and then the difference between the two. This is illustrating the tally reports that I mentioned to you. So if we kind of look through the report from the top down, you can see the agency name and where you're located, provider number, but then looking at the reporting period, and what's very important is to notice the legend, which is on the left-hand side there, third down. So it's telling you what how to interpret this patient's findings. So you've got X meaning that their outcome was achieved, the 0 meaning that they did not achieve the outcome, and U meaning that the outcome didn't relate or was not applicable for that patient. So again, you don't have to be a rocket scientist to know that you want to be zeroing in on the zeros. And those are the patients that, say, for example, you see that your improvement in toilet transferring is lower than you would like, and you're thinking you really want to focus on that, then you might want to look at Douglas Do-Right, nice name, Douglas Do-Right. Look at Douglas's record and drill down and see, okay, what was it that was happening with him, and was there something that we could have done in particular with him that would have improved his outcome? And then taking that, the next step would be, is there something from a process standpoint that can be applied to patients across your agency that could impact that score? So that's really just one example of how to drill that down. So looking at what is the plan and how are we going to do this, as I mentioned, you really want to drill down to per patient, because that's really where you're going to see exactly what's happening and what can you do to impact that. So the chart auditing is something that we all need to do, unfortunately. I know in this day and age of electronic medical records and all of the things that are automated in our world, we would love to be able to push a button and have it all ready for us, but unfortunately, we're not there yet. So we still need to go back to the chart and drill down and say, okay, what's going on with this particular case and how can we learn from that? So the example that we're using here today is looking at your acute care hospitalization. So say when you ran those reports, you found that your acute care hospitalization rate was higher than you wanted it to be. You want to look at which patients did get readmitted. So you'll run that tally report and then drill down. Look at was it a preventable hospitalization? And if it was, what targeted plan could you create that could help to address that? Also, if you were looking at an area for medication compliance, is this something that you can impact? If there's a reasonable goal, or is there just stabilization, which is more appropriate? And if you could have improved compliance, what could you have done to do that? So the PDSA, and I'm sure that most of you are familiar with that, but I'll just identify what that acronym stands for. So plan or P stands for plan, and that really includes collecting and analyzing data so that you can determine the trends, and that really is all of the reports that we've just been talking about. The D stands for do, and that really speaks for itself. So what changes can you implement? This could be OASIS training or some patient experience initiatives to improve your survey scores. But it's really, what are you going to do about the data that you found, the analysis, the trends that you found? Once you start a plan and you start doing something about what you've identified, you need to study the impact of those changes. And again, that's what the CASPER reports will enable you to do. So put your plan in place, implement it, and then go back to those reports and see, are you making a difference? Is it helping you, and is it improving the outcomes and the process outcomes that you're trying to achieve? And then the last letter, A, being act, and that is to revise the plan or keep it going because you're seeing the improvement that you want to achieve. So looking at the D for do, and we're just trying to offer you some suggestions on things that you can do to implement your plan. Again, you run your reports, you've identified some of the trends, you see what you want to improve on, so what can you do about it? Well, there's a few examples listed here. This is by no means an all-inclusive list. Obviously, staff education and engagement is a key piece. Why is this important to your agency? We talk about motivational interviewing all the time in patient care. I think we need to really challenge ourselves to say, what is going to motivate our staff to engage in these plans? Why does it matter to the agency? Why will it matter to your staff? And help to make it pertinent for them in their terms so that they will really just embrace what you're presenting, understand why you're proposing it, and really give them the information that they need to be able to implement the strategies that you've identified. Looking at the patient education engagement materials, the BPIPs that are available on HHQI, as you know, this is a tremendous resource to you, and I hope that all of you are accessing the data that's available and the resources that are available on HHQI. The BPIPs, they do have the Call the Nurse First program. This is a great initiative and strategy to impact your hospitalization rates, again, so that your patient calls the nurse before they just, get in the car and go to the emergency room. Or the personal emergency plan. These are just two examples of the BPIPs that are available on HHQI, And again, I would really encourage you to go to that site. If you're not registered, register and access that information. Another key area to implementing the plan, as we all know, is getting our doctors to cooperate and assist us in our goals. So much of hospitalization depends on the physicians that you're working with, the physician that might be on call when you reach out to them because a patient gets into trouble. So looking at whether you can have some what-if plans with the doctors. So really trying to brainstorm and put some plans in place. Again, looking at that acute care hospitalization example that might prevent the patient from going to the emergency room. Obviously, if they need to go, that's fine, but what can we do with the doctor to try to identify some parameters, whether it might be blood pressure, whether it's maybe additional Lasix for someone that might have CHF. I'm sure you have many examples where you've enlisted the doctors to help you to impact your hospitalization rates, and we need to just try to continue to expand that and to drive that home. And last but not least, we listed just identifying what data you're going to collect as you implement the plan. And again, the reports that are available on CASPER are much more current than what's available in Home Health Compare, but would encourage you to also look at some specific items that you can access possibly through your EMR or through your OASIS scrubber that can help you to get even more current data that's going to show you how to study the impact, that big S of the PDSA, study the impact of your changes, how often are you going to do that, put a plan in place for that, and then again, look at whether you need to act to revise the plan. So we talked about, as I mentioned, studying your progress and seeing how you're doing in this initiative, tracking the rates, as I mentioned, using your scrubber. We have identified the M items here that you can use to track your acute care hospitalization piece. You also can do the CASPER home health trend analysis that I referenced, as well as the agency patient-related characteristics case mix analysis summary report. That's a mouthful of a report, but you can look at that as well. So you need to identify, again, and make a plan of what this study is going to look like for you. How often are you going to be doing it? And again, so important is communicating your progress to your staff. The worst thing any of us can do is to put a plan in place and then not circle back with the staff as to how they're doing, because it just will die on the vine. So you need to keep it alive, you need to study it, and communicate with your staff as to how it's going. So once you've done that, what is the data telling you? How is your staff appearing? Are they motivated? I talked about that motivational interviewing piece. Possibly have your staff on a task force with you. When I worked in the agency I was at, we brought field clinicians in as part of our performance improvement plans. They were the ones that really knew what was happening in the field. And always ask the clinician that's your most problem clinician to come in and be part of your task force, because you can guarantee that those are the ones that are going to be talking to all the other staff, and they will talk it up. They will be your greatest advocates. If you can get them on board, you'll be safe and ready to fly. So again, if you can include them, the more you can include them, the better. Part of this revision is obviously what are some of the obstacles, and this is something that unfortunately we're all too familiar with. You can put great ideas in place, but there may be obstacles or one particular physician that is just not going to be collaborative. Well, we just need to identify that and move on. So just be aware of what your obstacles are, and then how can you reduce any of those obstacles so that you can improve the outcomes. So hopefully I've given you a lot to think about. As I mentioned, we're here and all of the home health leaders are here to answer your questions and be available for you, but would love to address any of the questions that have been sent over. So I'll let Olivia read them for all of you now.
Thank you, Ann. If you'd like to ask a question, you can press #6 on your phone to unmute your line, or you can pose a question in the chat box. Just make sure you're sending it to all participants. Just so everyone knows, the link for the handout for this presentation will be available on our website. The link is there, and we will be sending out a thank you email with the link again as well. So currently, I don't know if the link is up. We had to make a few adjustments to the presentation, but it will be up shortly, and it will be in the email. And looks like we have a question from Ellen. Please explain risk adjustment and which report we should view. Ann, do you think you could answer that?
Sure. So we would need a whole nother session to talk about risk adjustment. That's a really tough area to give a high-level highlight on. But risk adjustment really is looking at the difference of your patient population and trying to say, is your case mix younger and healthier, or is your case mix a more old or frail population? So it will really be comparing you to your peers. For example, if your case mix was a younger, healthier population, and looking at that same example, the acute care hospitalization that we talked about, if your population's younger and healthier, your acute care hospitalization rate should be lower than an agency whose case mix was more old or frail. That makes sense, right? So the risk adjustment is exactly that. It's adjusting your outcomes based on the complexity of your patient population. The more complex your patients are, or the higher your case mix, the adjustment will be in your favor. So if your actual acute care hospitalization rates were the same, if you have a young population but your ACH rates were the same, your risk adjustment would raise your outcome score to reflect that younger, healthier case mix. So it's really giving a consideration for the patients that you serve. The reports that are available for that are actually in the names of the report, so it does specifically say risk adjusted. So you can see, I'm just looking for my list of the reports, but there are two, the risk adjusted outcome and the risk adjusted process reports are the ones that you would want to be looking at that is taking that into consideration. I hope that answered that.
We have another question from Bonnie. What is the reference group that was discussed in the first report that described?
So the first report that we described, I'm just circling back here, bear with me. So I believe you're talking about the agency patient-related characteristics report. That was the title of the slide was data. And that actually is looking at all, I think I mentioned the reference sample. It was 6316068. So a large reference sample. That was the reference group. That's all agencies that report OASIS and how your demographics, how your payment source, how your episodes, how your inpatient discharge, medical regimen, how all of those compare to that huge reference group of all OASIS submissions.
Thank you, Ann. Again, if anyone has any questions, they can pose it in the chat box, or they can press #6 to unmute their line. Just give it a couple more minutes.
Hello?
Hello?
Yeah, we have a question as well.
Okay, go ahead.
Hi there.
Can you tell me what the time period is that you measure hospitalizations or rehospitalizations or emergency room visits?
What the time frame? I'm sorry. Say that again?
When you're taking your data to consider whether a patient has been admitted to the hospital, or sent to the ER, how much time are you looking at? You're looking only through the time that we are caring for the patient, or if you do it any time after the patient is discharged?
So I guess there's a couple of answers to that. It's a great question. So when you're looking at the reports that are available on CASPER, you will be able to click on a specific period. So the current period. So that will be looking at. It's really an established time frame. So it's not something that you can specify. It's really what's been loaded and is available to you. When you're looking at drilling down on your, like a PDSA plan, I would recommend, as real time as possible. So if you do have a patient that gets readmitted, we had, as I mentioned, a readmission task force, and we would gather on a weekly basis to look at those cases. So it was very real time, so that you could actually implement some lessons learned on that particular patient. Because as we know, a patient that goes back to the hospital is more at risk to go back again. So you want to kind of do both levels of that. Looking at the CASPER, that's going to give you more of a high level, but also a real time in terms of your active clients that do get readmitted. Does that make sense?
Yes, and I guess if I could go no further then, if we discharge a patient and that patient is subsequently admitted or visits the hospital for any time period, are we still penalized, or once we discharge a patient, are they no longer looking at statistics for rehospitalization or ER visits?
That's a great question. Actually, they are not looking at that for home health as yet, though all indications are that they will. That is not a measure for us as yet. As you know, with bundled payments and shared savings plans, they are actually the health system, the ACO, or some of the level 3 plans for nursing homes that are being penalized for readmissions from, when they discharge someone. If it's within that 30, 60, 90-day period, they can get penalized. We do not get penalized currently. The one penalty that could occur is that your referral sources, so the hospital or the nursing home, if they see that you've got, a lot of the patients that they refer to you end up going back to the hospital and they're getting penalized, I would dare say that their referral pattern to you might end up getting impacted. So that would be kind of an indirect penalty, obviously. So, it's something that, we need to be aware of as well. Does that make sense?
Yep.
Hello.
Hey,
How are you?
good. How are you?
Good. I feel like I'm on a talk show.
I know. I know you mentioned rehospitalization. You know, you're looking at that. What are other criteria? What other area you're looking at? You know, that you agencies are being judged. You know, did you understand my question?
So what criteria are we looking at for rehospitalization?
No, you said one of the areas that, you know, they're looking at is rehospitalization. What are other things that we have to, you know, to make sure or look at or work on, you know, apart from rehospitalization, what are other areas that they're looking at, that you guys are looking at? What's the process?
That's a great question. So what I would do is I would actually look at your star ratings. So you know, if you go on to Home Health Compare, look at what your star ratings are, and try to see how you're scoring in the star ratings. If you're low in some of the areas, whether it's ambulation or some of those other key areas, you'd want to look at those with your CASPER report, so that's going to be more current data on those same measures. And then you really want to look at trying to impact those. As I mentioned before, you know, the star ratings, I don't know if you all realize, but all of the star rating indicators are in the value-based purchasing measures. The only one that isn't is the timely initiation of care. So all of the star rating indicators are part of value-based purchasing. So if it were me and I was still running an agency, that's where I would start. And then going to your CASPER reports to get more current information in terms of those indicators, and then trying to put a PDSA plan in place for the ones that you're, you know, scoring below, that are feeding the stars and making you maybe 3 stars instead of 4, 4.5, or 5. So, does that make sense?
Yeah, it does. All right.
Great.
Thank you.
You're welcome.
If anybody else has any other questions, you can press #6 to unmute your line, or you can go to question in the chat box. While we're waiting, I think Ann wants to talk about the slide that we have currently up right now.
Yeah, thanks, Olivia. So I just really want to emphasize to all of you, don't listen to this webinar today. Go to sign on and not be able to sign on and just say, oh, geez, I can't do this, and give up. We're here to help you. This is really important to your success, to your sustainability. You need to really make this part of your normal practice. And again, we are here to support you. So you can see the 6 New England states listed here. And the home health leads, you've got experts in each of your states that are dedicated through the QIN-QIO that are here to really be your resource. So don't feel like you're alone. We're here to help you. So thanks so much, everyone. Yeah? Yeah.
Hello.
Yes, hello. At Home Health and Hospice, I just have a question on the risk adjustment because I'm still confused on it. Is that based on each individual patient, or is it based on the population of your total agency? For instance, we have several younger patients that are having joint replacements that may be in their 50 and 60, relatively in good health, except for the need for the joint replacement. We have several patients that are chronically ill, as well as the illness management patients. So is it based on just one individual patient, or is the risk adjustment looking at the whole patient population?
It's a great question. So the risk adjustment is based on the population, but it's based on the case mix of your individual patients. So So, as you know, your case mix really drives your HERG score and drives your reimbursement. And that's particular to that patient and that OASIS assessment. The case mix for all of your patients kind of drills or equals your patient population case mix, and that is what's taken into consideration for the risk adjustment.
Okay. Thank you.
Does that make sense?
Yes, it does. Thank you.
Good. You're welcome. Okay, so I know Olivia has put up our next webinar, which is Kathy is, I believe, doing that. Is Kathy doing that for the HHQI, the Cardio LAN webinar, which is Thursday, June 16th from 2 to 3. You can see the link there. We invite you to join that. Hope that you'll tune in, and Kathy will be happy to share her words of wisdom on that time, at that time.
Thanks, Ann. I just want to thank you all for a great discussion, and especially thank Ann for filling in for Kathy. I just have a few last-minute announcements before we end today's call. When you close out of this webinar, the evaluation will automatically pop up on your computer. If you could please fill that out, we would greatly appreciate it. If you don't have time to fill out the evaluation right now, or you're currently sharing your computer with someone else, you'll receive an email tomorrow morning with a link to the eval, as well as a link to the event page on our website. A PowerPoint presentation will be posted on our website momentarily. We had to make a few adjustments to it, but it will be posted today, and within the next few business days, a recording and a transcript will also be added. Be on the lookout for emails about our next webinar. As you can see, it is the Cardio LAN webinar. The New England Home Health webinars will be taking a break for the month of June because Kathy is presenting on this webinar. Thank you again for attending, and I hope you all have a great day, and thank you again to Ann Olson.
Thanks, everybody.
Bye-bye.
Bye-bye.
The router has disconnected. The conference will be terminated in 5 minutes.